Okay, what we're going to do today is to talk about a new form, actually two new forms. And as of yesterday, the old forms, anyone who remembers them, called the Home Health Advanced Beneficiary Notices. We had 3 of them once upon a time. And as of yesterday, they were to go away. So if you have any in your cars or any in wherever they might be, toss them, because they are no longer valid any longer. Okay.
What do they look like?
You don't know then. Don't worry.
Trust me, you didn't use them.
You didn't use them. Yeah, we know you didn't use them.
Oh, okay.
We're really sure about that. But you could have them, stashed.
Okay.
Just don't use them now, okay? Anything with HH, ABN, you don't use. Okay, but we have 2 forms. One is called a Home Health Change of Care Notice that we are to use. And we have an Advanced Beneficiary Notice, which you will use very infrequently. And when you do, you will contact your manager and or the UR department, specifically Vicki, who will walk you through it and will help you. It'll be used very infrequently. We're going to talk about it a little bit, but we're going to really talk about the Home Health Change of Care Notice, Hhccn. All right. So you're going to use these forms only with Medicare fee-for-service patients. Only. No Medicare Advantage, no Medicare Medi-Cal, Medi-Cal Optima, nothing else. Only regular Medicare. Okay? If it traditional, regular. Yes. Fee for service, FFS. Okay. Anyway, that makes it easier. You're going to, if you look at this part of your, oops, wrong. On yours, yes. I picked up the wrong one. It'll look like this. Kind of like this. It's on the second page. Is it not on the back? There it is, right there. On the back of page 1, you will see something that looks like this. That is the Home Health Change of Care Notice. This is not an optional form. The ABN is optional. Only when you are going to have a liability, a patient's going to have a liability, financial liability. But this form is not optional. This form is used in 2 different reasons. One, and this is the one that you're going to use it the most, is when you have a patient, you have gotten orders, you had a plan of care, it said you were going to go out 3 times a week for 2 weeks, and then 1 time a week for the next 7 weeks, let's say. And after the 4th week, you say, patient doesn't need us anymore. We can either discharge or we can reduce our visits. Not go up. You have a new order, that's fine. But if you're decreasing your frequency or stopping your frequency outside of what your plan of care stated, this is what you need to do. For the Medicare fee-for-service patient, you have to alert them that you have made a decrease in your visits, of what you told them that you could do before. Okay, does that make sense? Mm-hmm. No. Again, it's to alert the beneficiary that you have reduced or stopped something that you said you were going to do in the beginning, your plan of care.
So if your plan of care on start of care is scheduled for 3 times a week for 2 weeks, then 2 times a week for 2 weeks, then 1 time a week for 2 weeks, and you followed that whole thing, you don't need that.
That's right. That tells you, number one, how do we reduce the need for using this?
How do we reduce it? We
Uh-huh.
try to have as accurate a frequency from the beginning.
Have a very tight rein on your frequency. Don't go out 9 weeks. Think, write a new order rather than go out 9 weeks.
And what
Okay?
if in recert, it's a different frequency than it had been the previous cert? The
That's
recert
okay.
covers the
Research
order.
is new. New episode, new orders. Okay?
Okay, suppose the one worsens or whatever, and
You increase.
Yeah, that's
Yeah,
That's
But you're
okay,
getting new
different
doctor's
thing.
orders for that.
Increase, you need doctor's orders for both.
Right, but do we need to change this?
No,
It's only to decrease.
or stop.
no, if you, let's say that you're going along and you're 2 times a week with one wound care kind of thing, and all of a sudden you go to wound vac. You need a wound vac. Okay, so now you're gonna go out 3 times a week. That's an increase. You do not need this. It's only when you decrease or stop your plan of care.
Now, did I misunderstand you? Did you say this applies only to the Medicare?
Medicare, that's right.
So your Medicare Advantage, your HMO patients?
You better tell them, but you don't have to do the form,
Okay,
okay? It's only Medicare fee-for-service patients.
only straight Medicare patients?
That's right. That's good.
If you're
Good question.
stopping before your frequency is finished.
If you're stopping or decreasing your frequency, the way you have
Had it at
had
the
your
beginning.
plan of care, correct.
If a patient refuses.
If your
not
patient
necessary.
refuses, doesn't matter, you don't have to do it, okay? There's, in the handout, I'll go through those areas. In fact, I can do it right now. If the patient refuses, if the patient moves out of the area, if the patient goes back to the hospital or someplace, to a SNF or wherever they might go, if the physician says, okay, you're done, you don't need to go anymore, okay? You don't need to do it. It's only if you are calling the physician and saying, we don't have to go out 3 times a week, we can go now once a week. That is when you use it. You have to have orders though. Still says orders. Here's a little box. Let's talk about this form. How do you fill it out? Okay, you put the patient name in there? Yes.
So the original start, let's say 1 week is 1, 3 weeks, 2 week 2 week 8. Patient went into the hospital, came back, we resumed the patient.
Then you're writing new orders.
Right. Do we need to use the form? But what happened, aren't we decreasing the visit because those periods are in the
Well, but
hospital?
this is because they went to a higher level of care. You don't
Okay.
have to do it.
Okay.
So if they move to a higher level of care, if the physician says, we don't need you, you don't need to come anymore, or whatever they might say, or if the patient refuses to have you come, you don't need the form. Now, we don't want to see in the record that the patient was refusing you all the time, so you don't have to use the form.
Are these forms going to be in the eval packs? Because I really think they should be there for the Medicare patients.
Vicki?
No,
No? Why
they're
not?
expensive NCR forms.
But the
You're
other ones
not
are
gonna
cheap.
use them on 80 to 90% of your patients. They're gonna be up front in the reception area, near the numbnocks. So you can just take a
few.
small few for your Medicare patients. Remember, this is only for your Medicare, which is like 30% of our patient population. So if we put them in the admit packet, we're putting in Medicare forms on 70% of the patients that don't even require this form.
Okay, here we are. We put in the patient name, we put in their identification. No Medicare numbers on the forms anymore, okay? We can only use their P number, what have you. We say, starting on, you tell them what date this is going to change. Then you say, item or services. If you're reducing, you put down registered nurse, skilled nurse. Now, they need to know what a skilled nurse is, but, okay. from how many times per week to how many times per week when you're reducing. If you're stopping, you say stopping the following visits, you say the discipline, again, skilled nursing. And then other, if by chance there's supplies, supply changes. Okay, they want this, but they can't have that, okay. If you see there, it says do not use abbreviations that are not understood by the beneficiary. Very important, because if we do, it'll make the form not valid. Medicare doesn't like us to use PT, because what is PT? Part-time, prothrombin time, patient, physical therapist, what else? Probably something else. So they don't like that. They want you to write out what it is that's actually changing. Okay. And then the reason for the change you have to pick. You have improved in your progression of care, the physician's orders have changed.
I thought you
Actually,
said
you
if
can have
the-
both of those.
I thought you said if the doctor initiated it, we didn't do this.
That's right, if the
So if his
doctor
orders
calls,
changed.
well, then you're not using it.
So,
But you have to get orders anyway. If you'll see here, it says your doctor's orders for your home care have changed.
yeah.
And then it goes, that's the box you would use if you decreased or stopped before your plan of care. Am I making myself clear? Okay, so if the doctor calls and says, you guys can stop, you don't need to go anymore, then you don't need this. Because you're not making the change to, you're not suggesting, initiating the change in the plan of care. The doctor is. Okay, you still need orders though. Okay, so that's the one that you'll use the most. There is another time when you would use it, and that is for agency reasons. And that is when the patient isn't safe at home, and they won't go to a higher level of care, or they won't get a 24-hour caregiver, or whatever it happens to be, but we can no longer take care of them. Pardon?
That's usually more than enough.
Right, because it's going to be a discharge. But you could, for a Medicare patient, you should use this, okay? Now, the other thing is that you, that the patient it's not safe for you, not, the patient's not safe, but it's not safe for you in the home. There's violence going on, there's weapons on the table, whatever, okay? That does happen, right? Mm-hmm. Okay, so when that happens, and it's a Medicare patient, this. Okay, one other, we don't have orders for the patient. We cannot get a doctor to write orders. Then you have no orders. We have to discharge the patient because you don't have any. Unfortunately, we generally find that out after the fact. You've already taken care of the patient and then we don't get orders. That's a problem. But if we know about it ahead of time, this is the form that one uses. And it's this box here, the second box, that says your home health agency decided to stop giving you the home care listed above. Now, one other reason would be that you have a patient who needs this whole array of disciplines. They need PT, they need OT, they need speech, they need nursing. Okay, and you don't have, I always keep picking on the speech one because that sometimes happens, okay? So you don't have a speech therapist. So the patient needs that speech therapy in this period. Then you may have to give up the patient to another agency because you don't have that speech therapist, especially if it's necessary and the doctor says it can't wait. Okay? This one. Okay, now we would help them. It doesn't say that in this little box, but you would help them, or the office would help find another agency that would have all those needs that the patient needed. Okay, then we come down, we've marked this, we've marked in here the correct areas, and you'll see in the reason for change, it says it's no longer safe for us to provide care and we don't have sufficient staff to cover. So that would be going into the second box. Also, we don't have orders. First two boxes in this part here go with this. We tried to make all of your decisions for you easy. And we put them in this box like that, but you have to explain it to the patient.
Except if it's not safe, we're not going out to get this.
You're not doing it, we're sending it.
Oh, you're
We're,
doing it.
we're,
Okay.
we're certifying it, sending it by mail, certified so that we have tracking. You're absolutely right, very good. If it's not safe, you're not going back out. That's good, that's good. Okay, if the patient is not the one who's signing it, if it's not the beneficiary, and it's the representative of the beneficiary, Medicare wants to make sure they can read that name. So if the patient's, or the representative's signature is not really very good, then what you do is that you will print the name someplace on here, either down here or up here in the additional information area, so that it's known to them in case they appeal it. Well, they can't really appeal this. So they bring it up, they know who it is. Or we have to send it, like we get AVRs and we have to send this information to them.
And we didn't create the form, by the way.
No, this form is Medicare's form. The only thing we did is put in this. This is what we could do. We tried to take the guesswork out for you so it would be easy.
So they're not allowed to appeal it.
Actually, on this particular one, they can appeal on this, just the decrease. They can appeal that. The part that they can't appeal is that if you say it's not safe, you say we can get orders, they can appeal that.
Excuse me.
Okay.
Gee, they didn't put their phone number on here to appeal though, did they?
Mm-mm.
Well, there's a comment there, if you see, it says you cannot appeal to Medicare about payment for the items or services listed above unless you both receive them and a Medicare claim is filed. So they can't try to defraud Medicare.
Right, we can't try to defraud Medicare, right? Okay, that's this one. That's the one you're going to use the most.
Yes. You might want to explain face-to-face to the teacher.
Oh, yeah. The other thing is, do you guys know we have to get this face-to-face thing on Medicare patients? There is, what? There is this face-to-face order that has to come from the physician for a visit that the physician has had with that patient face-to-face. And it has to be either 90 days before or 30 days after the start of care. If we cannot get that face-to-face completed accurately, or completely, I should say, and that they won't sign and date the form, we can't bill. I can tell you it is a nightmare for the people who have to try to find this and get it. It is an absolute nightmare. And the CMS and their payers, their MACs, they call them, the contractors like us, for us, it's NGS, you don't need to know all this. But anyway, they're denying up to 70% of all records that are being sent to them because of the face-to-face. So it's a big deal. Unfortunately, again, we find out about this after we've taken care of the patient. So we're on the hook for it.
Are we supposed to have the form that they did see, or the doctor has the form that they did see him?
We send that form to them.
To the doctor?
Yes, we do it. You don't have to do it.
So then,
This is one thing you don't have to do. The one thing that would be important, though, is that if they did not see that doctor, a doctor 90 days before you brought them on service, or we brought them on service, it's important for you to tell that patient, Medicare only, that they need to go see their doctor within 30 days from the time you start. Okay, that is important. And we used to have a little form someplace, a letter that went out, and I don't think that's being done anymore. Is it? I don't know.
Now, is this the primary care or the doctor that's ordered our, because they have to have a doctor to order our services?
Right, we have to have a doctor that signs the plan of care, which we call the certifying doctor, and that is the one we would like to have sign the face-to-face, but sometimes it might be the hospitalist that will sign the face-to-face. or the doctor in rehab that'll sign the face-to-face, or the doctor in the SNF.
Okay.
We're trying to get somebody, okay? Anybody.
As long as anybody
not
signs it, then
anybody.
we're good.
It has to be completed and signed and dated. Completed.
And so if it's not, what happens?
We don't get paid.
Okay, we don't get paid, but we don't know that. Do we still provide care?
Well, if we find out about it and the patient's still on service and we know we can't do it, then we would ask you to do this. We would contact you to say the next visit, this has to be done, and then we're out. And it's number 2, second box, and you would say, we do not have physician orders or a face-to-face. Okay? As I said, most of the time this happens after you're done. Because that's when we start really trying to do it. Okay. Now, how much have I
But the goal
missed
would
here?
be is that they see them within that 30 days of coming out if they haven't seen them.
If they haven't seen them before. Absolutely.
The ones where you guys could be instrumental is the sick little old lady that calls up the doctor's office and won't come into the doctor's office because she doesn't feel well, and so they send out home health to check out the situation. Those are probably the most, those are the ones where you guys could be the most proactive, that they need to get into the physician's office within that first 30 days. You know, the ones that came from a hospital were seen by a physician, so it's just the ones from the doctor's office. The daughter called and there's a sore on the bottom. Those are the ones
Or they're constipated.
Yeah, those are the ones that get us into real trouble if they don't go into the doctor's office.
And if
And then it's just the Medicare only.
And if they're incapable of going into
Then
the
that's when
doctor's
we need
office,
to be talking about having a house call doctor.
And it's 90 days before and 30 days after.
And it's 90 days before for the reason,
yes.
we're seeing them in home health.
Oh,
So if 90 days
constipation.
ago they were seen for CHF and the reason we're seeing them is for a pressure ulcer, doesn't fly.
It's very difficult. If you think about it, 90 days before, how come then we're waiting 90 days before we're seeing the patient? It's like, so you almost have to have another one. But the patients need to be seeing their doctor. And I know you ask about it. Do you have a doctor's appointment? Do you have this, whatever? And with the patients that are coming out of the hospital and they've had some acute kind of thing that happened, like a surgery or whatever, then they're going to go see a physician. May not be the physician who signed our face-to-face, or hopefully will sign our face-to-face, but they're going to see a physician. If there is one, please try to move them to get them there.
What about patients who've been on service for a while, and they are only seen by their physician once every 6 months because they're managed well?
With Medicare, it's the first start of care. So if they haven't had a break, okay, it's only that start of care one that we're worried about. But if they if they stop, and then we have to start them again, then we have to be concerned about that. Okay? Is that? So we're not doing it every cert period, thank goodness. Right, amen. Okay, let's go to the ABN quickly. If I can find my, here it is. Okay, we are on page 3. Okay, we talked about how you can avoid the Hhccn. We don't want to do lots. You don't want to do lots, but you have to do it, you do it. Okay, ABN is the one that you're not going to use very often, but you need to know about it. Now we're using the ABN, not an HHABN, but an ABN that is being used by all providers except for SNPs. Okay, there might be another one, but for SNPs right now. Okay, this is when the patient may be potentially financially liable for paying for whatever it is, whatever service it is, whether it be supplies or whether it be skilled nursing or whether it be the aid. We do have some cases, they're kind of like down south, but we do have some cases in which the patient has done one of these and they are paying for the aid. because that's what they want. And there's no, why wouldn't we cover it under Medicare?
Say that again? No skilled
Okay,
need or something?
no skilled need, exactly. No skilled need, so therefore there's no need for a PT or a speech therapist or the occupational therapist to continue on with the aid. There's only that they want the aid. And we have no reason to be out there because we've met our goals. Patient is now custodial.
Wouldn't they just go to private duty?
Yeah, that is.
They could, they absolutely could. But in some cases, they wanted a particular person, I believe. They had grown to love that person, and so therefore, we can do that. Okay?
So does
But
it
private
also-
duty, you go to private duty, we don't have to do
And
this,
supervise.
okay?
We've never done this in Orange though.
Okay.
But what does happen though is, because what you need to see are what the options are, is there people that are insistent they could use more therapy when we don't see that there's a skilled need, or someone was insistent that they didn't want the physical therapist anymore, but that they couldn't do their bath alone, so they wanted the bath to continue. So when you give them this and say, okay, but we need to tell you, we don't think Medicare is gonna pay for it. So you got, what you need to understand is that we'll send the bill to Medicare. You have the option for us to send this bill to Medicare, but if Medicare denies the claim, you are financially responsible for the claim, for paying the claim.
And we may already bill them. We may start billing them immediately when they do this, if they do it, okay? Now, generally when you get to that part, I have to pay what? Per visit?
And they won't.
And then they go, no, as long as Medicare is paying for it, it's okay, but once I have to pay, maybe not. But there are, as I said, down south, there are some people who are paying for it. Because they want that person.
Do you have an idea of what the cost for the home health aid is?
I have to ask finance, because that is one
It's
of
on the back of
things.
the consent.
So it's, okay, so it's just like that.
But that
So
is
you
the
can't-
maximum. That's the maximum we would charge them. And generally, billing has a different charge master thing that they use, okay?
The one example I think that we would more than likely use this is Medicare patients who have porta caps. If we're not infusing something, but they want their porta cap accessed and flushed, they have to pay out of pocket for the port supplies.
For the port supplies, and this is
Right.
coming, that it comes from pharmacy.
Correct.
And so
Okay.
it wouldn't have these things in there, it has pharmacy
Pharmacy stuff.
things in
Okay.
there. And they would get an ABN. In fact, the place in this building that uses the ABN the most is pharmacy. Because they're doing antibiotics and it's never covered by Medicare, all things like that, okay?
This is an excellent example
is.
though. Look at this form. Okay, it says here, skilled nursing, so in column D, your person with a porta cap.
Yeah.
Skilled nursing, then we go to the reason Medicare may not pay, and let's say that the patient isn't homebound. You are not considered to be confined to home and do not meet criteria. Cost, then you can say what the cost for your nursing visits are.
Right.
So you can put down the cost per visit, and then it's weekly, times 9 weeks or whatever.
Right.
Or just
Then
per
visit.
visit, and then it could be whatever.
Then they have the option of saying whether they want you to go ahead and bill Medicare for this and understand that they're going to be liable, or whether they get it that they don't.
Gotcha.
That's exactly how you would use this form.
Okay.
Okay.
So on this particular form in the box, you see I took away all of your ability to have to write it out and wrote it out for you so that you don't have to do that. And it says skilled nursing, physical therapist, occupational therapist, blah, 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 blah. Okay. And then there's the supply issue, but it's not when pharmacy's doing it. It would be when we're supplying it. Let's say they wanted to continue getting wound care supplies from us. Well, then we'd have to find out what are the wound care supplies and what would billing charge them, and we'd have to put that on there. But see, that's why we don't have these out for everybody. It's going to be very infrequently, and it's going to come to your manager and then to the UR department. Yes.
What about if you go out, you do a Medicare, it's the first visit, and you find out that the patient are not home? You give them one of these and tell them that we
Need
can
'em.
be out here?
Well, we're not going to admit, right? Now, you could, I guess, you could potentially say, okay, that's it, we're gonna give you this because we don't think Medicare will pay for it. But for the most part, you're just not going to admit that.